Coming up in this episode of Dermatology Weekly, data on the potential risks of COVID-19 in psoriasis patients is limited, but it's also reassuring. Also, red hair in women is linked with elevated CRP levels. This is Dermatology Weekly. And welcome to episode 87 of Dermatology Weekly. Following the news and the peer-to-peer portion of the show, resident columnists Dr. Daniel Mazzori and Dr. Nadine Shabib talk about how images of skin of color are not well represented in dermatology training resources such as textbooks. Don't forget, you can email the show at podcasts@mdh.com. You can also tweet at us or participate with us on Twitter at mdhderm. There are show notes available wherever notes are found in your app. They include relevant links, including links to the stories that you're going to hear in the news. And now, this week in dermatology. For patients with psoriasis who are concerned about their outcome should they contract COVID-19, there's no evidence to support stopping biologics or systemic agents. That's according to Dr. Christina Duffin, who is the chair of dermatology at the University of Utah, which of course is in Salt Lake City. Dr. Duffin presented a summary of published research and expert opinions at the annual Coastal Dermatology Symposium, which of course was held virtually. The National Psoriasis Foundation, or NPF, has provided similar advice. The NPF has created a COVID-19 task force, and it maintains a COVID-19 resource center on its website. That website's available via the article in the show notes. Many statements are phrased cautiously, and clinicians are encouraged to practice shared decision-making, but the NPF guidance supports continuing or starting effective therapy among those who are not infected with the coronavirus. The NPF guidance states that patients with a new diagnosis of psoriasis should be aware that untreated psoriatic disease is associated with serious impact on physical and emotional health, and, in the case of psoriatic arthritis, can lead to permanent joint damage and disability. Overall, the existing data generally suggests that most treatments for psoriasis and psoriatic arthritis do not meaningfully alter the risks of contracting the novel coronavirus or of having a worse outcome of COVID-19 illness. However, chronic systemic steroids are an exception. Dr. Duffin reviewed recently published studies that evaluated whether psoriasis or its therapies increase risk of adverse outcomes in patients with COVID-19. She pointed to several which associated systemic steroids with hospitalization or other markers of severe disease. The NPF guidance also recommends avoiding chronic systemic steroids in patients with psoriasis during the current pandemic, if at all possible. In patients with psoriatic arthritis who require systemic steroids, the guidance recommends the lowest dose necessary to achieve the desired therapeutic effect. However, this is not necessarily true for patients with psoriasis and COVID-19 infection. Based on the potential for systemic steroids to improve outcomes in hospitalized patients with COVID-19 who are requiring oxygen, for those patients, steroids should not be withheld when the justification is concerned about the potential risk of flares with withdrawal. The NPF guidance specifically cautions against the use of hydroxychloroquine or chloroquine for prevention or treatment of COVID-19. In addition to an uncertain benefit, these antimalarial drugs have been associated previously with flares of psoriasis, and Dr. Duffin agrees. She went on to warn that COVID-19 infection itself is a potential trigger for flares. She cited 2 case reports of flares that are associated with psoriasis. Although one of the patients she discussed had also been exposed to hydroxychloroquine, Dr. Duffin said that the risk of psoriasis flare does make sense based on previous associations made between flares and other viral infections. For protecting psoriasis patients from infection and managing COVID-19 in those who become infected, much of the NPF advice is consistent with that offered by patients without psoriasis. This involves practicing infection control that reduces the risk of transmission. Both the NPF guidance and Dr. Duffin suggest telemedicine is appropriate for limiting inpatient visits under pandemic conditions. Further, patients with psoriasis are more likely than the general population to have the comorbidities associated with poor COVID-19 infection outcomes. Despite this, Dr. Duffin called the overall data evaluating susceptibility among psoriasis patients reassuring. She cautioned that the data are still limited, but the evidence so far suggests that neither psoriasis nor biologics are independent risk factors for acquiring COVID-19 or having a worse outcome should patients become infected. Dr. Duffin did call for more data, though. She said that clinicians need to consult the NPF website for updates, which is a fluid situation. And we move now to new data suggesting that red-haired women were significantly more likely than women with non-red hair to have elevated levels of C-reactive protein, which may increase risk for cardiovascular conditions. This is according to data from the Nurses' Health Study published in the Journal of Investigative Dermatology. The Nurses' Health Study is a cohort study that includes more than 121,000 women registered nurses in the U.S. In the study, researchers analyzed blood specimens from just under 9,000 women, which were collected between 1989 and 1990. The natural hair color of the participants was determined by asking them their hair color at the age of 21. The choices were red, blonde, light brown, dark brown, or black. Overall, 4.3% of this cohort had red hair. The researchers report that the average CRP levels for women with red hair was 3.7 milligrams per liter, compared with 3.3 for women with blonde hair, 3 for women with light brown hair, and 3.2 for women with dark brown and or black hair. Using the CRP levels for red-haired women as a reference, women with blonde, light brown, and dark brown or black hair averaged significantly lower CRP level than those with red-haired women in an age-adjusted model. The researchers also reported that women with non-red hair significantly had lower odds of high CRP levels compared with red-haired women. The study was limited by several factors, including the use of self-reports for hair color and the relative homogeneity of the Nurses' Health Study, which has a population of mostly white, female healthcare professionals. Despite all of this, the findings of significantly increased CRP levels could potentially explain a prior report of increased risks of cardiovascular disease and cancer in red-haired women. However, the researchers also wrote that they observed similar associations in the study between red hair and cardiovascular disease and cancer. And finally today, our weekly COVID-19 update. I know that most weeks it seems like we have at least one or two COVID stories, but we'd like to update you with our final story on COVID-19. Let's discuss something that's been talked about for a while, mouthwash. Multiple mouthwash and oral rinse products wiped out a human coronavirus closely related to the novel coronavirus in this pandemic in a laboratory comparison study. Listerine antiseptic led the list of the most effective mouthwashes for inactivating the coronavirus. Interestingly, a 1% nasal rinse solution of Johnson's baby shampoo also worked, as it eliminated up to 99.9% of the viral load in the in vitro experiments. In contrast, the use of a neti pot nasal solution, the thing that you put in your nose when you have cold symptoms that runs through your sinuses, that yielded no decrease in the virus levels. The study was published in the Journal of Medical Virology. You can find a link to that in the show notes, of course. The authors wrote that the mouthwash and hydrogen peroxide oral rinses in the study are widely available and easy to use. The lead author, Dr. Craig Myers, is a PhD professor at Penn State College of Medicine in Pennsylvania. He wrote that he would recommend the use of the rinses on top of wearing masks and social distancing, as it could add a layer of protection. Dr. Valerie O'Donnell is a PhD and co-director of Systems Immunity Research at the Institute of Cardiff University in Wales, and she commented on this research. She said that the study adds to and further confirms the recently published evidence from virologists in Germany that reports that mouthwash can inactivate the coronavirus in a test tube. She continued by saying that while this is great, there is still a lack of in vivo evidence since we know the virus will be continually shed in the mouth. So the question now becomes, by how much could mouthwashes reduce viral load in the oropharynx of infected people? And if it does work, how long does it work? The authors of this study noted that studies of people positive for COVID-19 using each product would be informative. It remains unknown, for example, if swishing, gargling, and or spitting out mouthwash would add or decrease the efficacy demonstrated in the lab results. The investigators of this study used the human coronavirus HCoV229E as a surrogate for the novel coronavirus. They noted that HCoV229E is analogous, and SARS-CoV-2 would have been more expansive, less available, and would have required biosafety level 3 laboratory conditions for testing. And that's it for the news portion of the show this week. Stick around. When we come back, the residents are taking over the ship. They're going to discuss diversity in training tools such as textbooks. You're listening to Dermatology Weekly. This is Dermatology Weekly. Welcome back to the program. It's time now to welcome our resident columnists at Cutis Peer-to-Peer, Dr. Daniel Mazzori and Dr. Nadine Shabib.
Today I'm speaking with Dr. Nadine Shabib, who is a dermatology resident at the University of Wisconsin-Madison. She and I are going to be talking about her latest Cutis Resident Corner column on the very important subject of dermatology resident education for skin of color. Thank you so much for joining me today, Dr. Shabib.
Thank you for having me.
So I wanted to start off by asking you about something that you addressed in your column, and that's your personal and professional reflections that led you to write about this important subject. In your column specifically, you wrote that you've spent the past few months reflecting on your dedication to anti-racism, both as a dermatology resident and outside of residency. And I'd love to hear more about that.
With all that has happened in the past few months, and with increased awareness and discussion on the anti-Black racism that exists in so many facets of our society, I've done a lot of reflection about the role that I can play as a dermatology resident. And what I realized is that so many parts of dermatology are centered around white skin. The way that diseases present on white skin is considered normal, and how it looks on darker skin is considered other or abnormal. And we often hear reasons like certain conditions look different on darker skin, but it's not really an excuse to just say that things look different. We have to be able to diagnose and treat all of our patients, regardless of their skin tone. It's really our responsibility to do better for our patients. And to that end, our educational resources should also reflect our patient population. And our patients who are Black often have legacies of mistrust in the healthcare system, from things like the Tuskegee syphilis study and other instances of systemic racism in our healthcare system. And so diagnostic uncertainty on the part of dermatologists can add to that mistrust. So I think all of this really highlighted to me the importance of being comfortable and competent in diagnosing and treating patients who are Black, and really patients of darker skin in general.
I couldn't agree with you more. And I'm going to quote your column for a second, because I thought you wrote it really, really profoundly when you said, it is not a valid response or excuse to say that certain diagnoses are harder to make because of darker skin tone, and that it is our responsibility to do better for all patients. I think you're absolutely right. And I commend you for using this challenging time as a time also for personal, professional reflection, and writing a column about this subject, and being with me today to talk about it. I think it's really important for everyone to have these sorts of conversations with themselves and with others, and move forward and improve upon themselves in their training. So thank you for that.
Thank you for saying that, because I think it's something that we sort of take for granted, that all of the pictures that we see in our dermatology textbooks are often of patients with lighter skin. And having that reflection was really kind of an eye-opening experience for me, in realizing that it's a field where so much is centered on lighter skin tones.
I think what's also very important to talk about is that the same kind of personal reflections that you had and the experiences that you've shared with us are actually also reflected in data that we have. And so in your column, in addition to just writing that images of skin of color are greatly underrepresented in dermatology educational resources, you actually reference several studies that have demonstrated this lack of diversity. And I think those studies are really eye-opening and important for everyone to be aware of. So would you be able to tell us a little bit about what these studies found?
Yeah, so there was a research letter that was recently published in the JAAD. And in that research letter, the authors looked at the number of images of dark skin, which they defined as Fitzpatrick skin types 5 and 6, that were represented in dermatology educational resources. So they looked at images from 8 resources that are commonly used to study dermatology, and that included 6 textbooks and 2 online resources. And these are really the resources that we are using every day to study dermatology. And of the textbooks, they found that Andrews' Diseases of the Skin had the highest percentage of images of dark skin at 19.9%. Visual DX had the highest percentage of all of the resources at 28.5%. And DermNet NZ had the lowest of all resources at only 2.8%, which is pretty dismal. And if when I read that study, I was just thinking to myself how often we refer patients to a website like DermNet NZ for them to have more patient education. Or I think to myself how dermatology is a field that requires so much studying, and we really rely on our textbooks for images and photographs of disease entities that we may not see that often clinically. And so if all of our patients are not represented in our resources, and if we're not seeing those patients in clinic, we're really not ever going to be able to accurately learn and diagnose certain skin diseases.
Absolutely. And especially too, depending on what resource you tend to favor or, tend to have access to, the fact that there's such a huge range in the percentage of photographs of dark skin from something like DermNet NZ all the way to Visual DX or Andrews, I think is also very important to consider and think about, especially, when you're seeking out resources to use.
And there were also a couple of other studies that really stood out to me. There was a research letter that had been published in the British Journal of Dermatology. And in that one, the authors looked at images in 2 dermatology textbooks. And the point that they made was that the number of images of sexually transmitted infections and skin of color was disproportionate to images of skin of color and non-sexually transmitted infections. And then finally, the lack of diversity in clinical images and research was shown pretty recently in some recent publications about the perineal-like eruption that's associated with COVID-19 that I know we've all heard a lot about with COVID toes. And there had been a research letter that was published earlier in the British Journal of Dermatology about how there were really no published images up until recently of the cutaneous manifestations of COVID-19 in patients with Fitzpatrick skin types 5 and 6. And this is despite the fact that COVID-19 is a disease that disproportionately affects Black individuals and other people of color. And in general, the authors noted that the findings were more subtle on darker skin because the erythema was harder to notice. And that inability to identify COVID toes could ultimately lead to a delayed diagnosis if practitioners are not able to realize it because of the patient's skin tone. So I think, unfortunately, there are kind of a lot of instances where skin of color is just not as well represented in our educational resources and also in research sometimes as well.
And I think, it's interesting what you mentioned there about, the fact that erythema, can be more subtle on darker skin and as a result harder to discern. But kind of going back to what you said earlier, just because something is harder to see in a darker skin tone isn't an excuse. It's not a valid response. We have to train ourselves to be able to pick up erythema that's harder to see, and that's just what makes a good dermatologist, is being able to do that. So, I think that's really the key in the message here.
I totally agree.
And I think it's also really profound, to talk about the second study that you mentioned, which is that, not only is it that, certain resources just overall have fewer representations of skin of color, but then the ones that do tend to skew towards certain diagnoses over others. And as a result, don't show the breadth of skin of color and the conditions that, appear with, in skin of color. And so I think that's also something that's very important for us to bring to light, to think about, for textbook publishers and editors to think about when they're coming out with their next editions, to really kind of reflect on that and try to dispel that disparity.
Yeah, I agree.
The other part of your column that I found really important and powerful was the section in which you talked about the efforts that you and your department have undertaken to strengthen the skin of color curriculum at the University of Wisconsin. And so I was wondering if you could share some of those efforts with us, because I think that a lot of our listeners can hopefully glean from that and be inspired to, try to do something similar or identical at their respective institutions.
So my co-resident and I, Dr. Annika Weinhammer, have been working on a quality improvement project this year under the guidance of our mentor, Dr. Dan Bennett, to really improve and strengthen the skin of color curriculum at our program. And this sort of started again with, I think, our own self-reflection about how we can do better as dermatology residents. It started off with me, committing to my co-residents that I wanted to make sure every didactic session that I gave would include skin of color. And from that, it has really kind of grown into a bigger project. So some of what we've done, it's now really a requirement for any lectures and didactics from residents and also from our faculty to include photos of skin of color. All of the residents were provided with 2 ebooks of skin of color. And I think that's something where I would recommend for residents to look at what resources may be available through their institution's library, to see what ebooks may be available. And in my column, I also included a long list of books from some dermatologists in our field who are really experts in this area. And then on that note, our department also sponsored for residents to attend the Skin of Color update virtually this year. And we've had dedicated didactics time in order to stream those lectures together. And they were really fantastic lectures. We've all learned a lot from them. In general, I'd really encourage residents to join the Skin of Color Society, which offers free membership for residents with a letter of good standing from their program directors. And again, just has really great resources to offer from skin of color experts in our field. So part of what we wanted to do was specifically to improve our educational curriculum for skin of color, but we also wanted to actively address anti-racism as well. And I compiled a list of anti-racism resources with input from my co-residents, and this list of resources was shared with our department really for anyone looking to learn more about the historical and present day manifestations of racism in our country. So this includes educational resources like books and documentaries, TV shows and podcasts. And it also includes a list of local and online Black-owned businesses to support and local Black-led nonprofits here in Madison as well.
I think that's really important too, because, that's creating efforts within the department, but that are beyond dermatology. And one of the ones that you talked about that particularly caught my eye is the fact that you guys are doing a resident book club in which you're discussing the book, How to Be an Anti-Racist by Ibram X. Kendi. And I just thought that was really wonderful because, in addition to being more intentional with the images that you're including in your didactic lectures, You're also doing things that don't necessarily have to do with dermatology, or at least, aren't specific to dermatology, like this book club. So could you tell us a little bit of how that book club is going? Because I think it is really a creative and fantastic thing. And I'd love to hear more about that in case anyone else that's listening would be interested in adopting something similar.
Yeah, so it's been going really well. And I think to your point, the lack of representation of skin of color in our educational resources is just kind of a manifestation of the systemic racism that unfortunately exists in our healthcare system and really in our society at large. So I think to address the lack of representation and the deficiencies that we sort of have in our skin of color education for residents in general, it's really important to be aware and educated about why those deficiencies exist. So the department provided books for the residents, and there are plans for, I think, wider department-wide book clubs, but at least right now we have kind of a safe space dedicated for just the residents. So we had our first virtual book club through Zoom earlier this week for the residents, and again with Dr. Bennett, our faculty mentor. So what we've done is we've divided the book into 3 different sections to discuss throughout the year. And we, at our book club, we had a discussion about some of our reflections and some of the major themes in the books. And really how that's tied into our personal experiences and also into the patient experiences that we've had. So we had a discussion about some of our personal reflections and some of the major themes in the book and how that's tied into our experiences with patients as well. So one of the major themes that came up a lot was the importance of being aware of our own personal biases and how to actively address them. And Ibram Kendi, I think, just does such a beautiful job of illustrating that we all hold racist ideas and beliefs. And instead of denying that these racist ideas exist or saying that we're a colorblind society, we need to actively work against them and address them as anti-racists. And he just does such a great job of outlining the racism that exists in our society and how it came to be and how it continues to pervade our society. So it was a really meaningful discussion. It was really great to hear everyone's reflections about it.
And from a sort of practical perspective, when you guys broke up the book into 3 parts, did you guys have residents just to kind of read it on their own, or did you provide questions for them to think about as they read? And kind of along the same lines, was the discussion moderated by someone? Was it open-ended, or did you guys have questions prepared in advance that were asked and kind of talked and thought through?
Those are great questions. So we sort of somewhat arbitrarily divided the book into thirds just to get kind of equal sections that I think were about 70 to 80 pages. And the residents, I think, have a couple of months in between the book club sessions to do the reading. We did not provide a list of the questions ahead of time. My co-resident and I moderated the discussion with some questions that were available through Ibram Kendi and also through the publisher. And to be honest, I don't think our discussion really ended up needing much moderating, because I think the themes that people brought up that really stood out to them were sort of aligned with the questions. And so I think there was sort of a natural discussion of what really stood out to us, sort of guided generally by some broader discussion questions as well.
That's great. Thank you so much. So I think that, I think that's very practical advice for how to do something like that, especially because, I think that a resident book club about a non-dermatology text, is probably not something that a lot of residents are used to and, may have a hard time finding the time to do. So sort of just hearing about your process in terms of time management with splitting up the book into sections. And then also it's great to know that, books like these and others, oftentimes the author or the publisher provide questions, for book clubs and discussion and reflection. So to turn to those to help facilitate a conversation if necessary. Although in your case, like you said, it didn't seem to be that way. So I appreciate those practical tips for people who may want to be doing something similar.
I think we also just really tried to be mindful of doing this in a way that was not going to feel like added work, and to give everyone enough time to get through the reading. The book is also available as an audio book through the library, and at least our local library, I think, has an unlimited number of copies, so there's no wait list for it. So I think there were a couple of residents who, listened to the book while commuting, and maybe got a little creative with finding the time for it.
Absolutely. And I think what's interesting along those lines is that in addition to the resources you've mentioned now, you also talk a lot about different resources that exist for education of skin of color online and on social media. And I think, tuning into the Skin of Color update resources is a great, option, especially because they're going to be available to stream through the end of the year. And are relatively affordable to access. But do you have advice on anything else that is out there online on social media that is free and that people can use themselves and work or even give to their patients?
One resource that I had actually read about in the news is a handbook called Mind the Gap that was written by a medical student in London. And that handbook focused on common clinical signs and how they present in Black and brown skin. I think it would be a great resource probably for a non-dermatologist who maybe is not as comfortable with skin diseases in general. Another online resource with a lot of clinical images is called Skin Deep. And it's available at dftbskindeep.com. So it's through an organization called Don't Forget the Bubbles. And so this project specifically is aimed at improving the diversity of pediatric skin images. And so they have on their website kind of a library of images and skin of color available for review. And I think that those images are also reviewed by their team of physicians. One online resource that I've also found helpful is an Instagram account called Brown Skin Matters. And it shows photographs of dermatologic conditions and skin of color. But the thing to keep in mind with this one is that the photographs are submitted by users and are not independently verified by a dermatologist. And then in general, there are so many accounts on social media by board certified dermatologists that often highlight issues affecting skin of color. So I think there are a lot of resources out there online and through social media if you're interested and are willing to look for them.
And I think something also that is pretty new has to do with Visual DX. I think we've come out with several new features to improve diagnosis in patients of color and to, filter images to match a patient's skin tone. And so I think, features like that are wonderful to also, think about when you're using a source like Visual DX. So that's something else that I thought was really exciting that I enjoyed hearing about earlier this week.
Yeah, and I think Visual DX in itself is already such a helpful resource, and to see the commitment they've had towards making sure that skin of color is represented in their resources, it's really great to see.
So with that, I just want to thank you again, Dr. Shabib, for bringing this important topic to light in your column and now this podcast, and for providing all of us with really practical solutions and tips and advice about how to improve skin of color education and dermatology residency, and arguably even beyond that. So thank you again for joining me. Until next time, this has been Resident Takeover.